Dear friends, good evening. After a long time, we are all meeting up on the Zoom platform after all the spate of physical meetings that we've been having. And it gives me great pleasure to invite you all for this webinar on complex interventions with imaging. And we have very eminent moderators and panelists today, and the program will be chaired by Dr. Balakrishnan Karthikeyan from Hindu Mission Hospital. Two very good panelists who are going to discuss all the cases, Dr. Jaishankar and Dr. DMT Saravanan. I think Madhavan has not joined us yet, right? So Madhavan is also expected to join later. And they will be discussing all the cases for you. On behalf of ACERT, I think all of you know about ACERT. ACERT is our cardiology society where we run all the registries, and we are now expanding into more education. We were doing all these educational programs during the lockdown. I think we are restarting them again. And hopefully this is going to be a continuous feature on a regular basis. Over to Dr. Karthikeyan. I'm not putting in any formal slides for introduction of people. I think all of us know each other pretty well. So I thought we'll not waste much time there, and let's go ahead with that. Karthikeyan, the screen is all yours.
So thank you, sir. I think without wasting much time, I'll invite Dr. Ashish Chopra from Triple. He'll be talking on a left main bifurcation PCI post TAVR. You can share your screen, Ashish. Great. Ashish, you are muted, so you can unmute yourself.
Ashish, unmute yourself, Ashish. We can't hear. Ashish, please unmute yourself.
Yeah.
Yeah.
Can you hear me?
Yes, now we can hear you.
Sorry.
Share your screen now.
So,
okay. Yes.
So it's an 8-year-old male presented with exertional symptoms for the last couple of months, which has increased for the last 1 month associated with the syncope. Coronary angiogram was done, which showed double vessel disease, and he had a critical valve of 0.95 square centimeter with adequate LV, and he had a grade 2 MR with a sinus rhythm. This was basically the angiogram. It's more of a left dominant system with the right being a small vessel. And if you notice the calcium on the LAD and critical, probably a significant LCX stenosis. So this was the valve critical area, tricuspid morphology as per the echocardiography. And obviously, thinking of double vessel, the discussion was between CABG with SAVR and TAVI with the PCI. Since his age, frailty score, and he had underlying diaphragmatic hernia on the lung, and so that was the reason we decided to choose for options of TAVR with the PCI. The parameters wise, annulus size was about perimeter was 72, area was 412, and other much of the details on TAVR, good coronary heights, a moderate calcium, all the leaflets different calcified, and he had a good femoral size vessel, which was more than 6.5. So on conscious sedation, I preserved the right femoral for the PCI, so hence took a right radial for the pigtail. I used a left femoral artery for the TAVI procedure. Pre-dilated with the 16x40, and the device chosen with the area as well as the perimeter was 24.5. So basically, our closure is one proglide with one angiosele. So this was your this crossed with a routine AL1 with a straight tip thermo wire. After crossing, place the exchanged with the Teflon wire, and pigtail was inserted. Hemodynamics was measured. The trans aortic gradient was about 37. This is the hemodynamics. And with exchange with the Safari 2 wire, and the pigtail catheter was removed. Pre-dilated with the 16 into 40 under rapid pacing of 180 beats per minute. This was the valve, 24.5 with a nominal volume. And the hemodynamics was good. He had a mild PVL, but it was more of a valvular leak. And this was the hemodynamics. The diastolic pressures were good. The index was good. So hence, we decided not to do anything with this. It was closed, and one proglide and one angiosele, and not much of an issue with the femorals. So coming to the highlight for the case was basically a PTCA. So in view of TAVI was done, we didn't want to do both the sittings in the same scenario. So we just staged with the first TAVI followed by the PCI after a couple of days. So right femoral access again this, and 7 French was placed. So basically my whole point of discussion was this is again our practice where what catheter to choose, especially post TAVI. Since it's most likely like a balloon expandable valve, how we use routine PCI. So hence it's an advantage in especially in a balloon valve, where in self-expanding valve we have an issue of accessing the coronaries. We have to either downsize our catheter, or it depends again on the anatomy as well as the sinutubular junction and the aorta size. So basically 0.5, if you want in a self-expanding valve, we can undersize and just. But since it was a balloon expandable valve, hence we chose a normal routine EBU 3.5. And now if you can identify the close, the criticality of the LAD and the LCX. So basically osteal LAD critically stenosed, and if you notice the calcium and if you can notice the calcium at the LAD and the LCX being a significant lesion. So both the coronaries were wired with the routine workhorse, such as one was run through and one was the BMW. So we did a pre-IVUS in the LCX. If you notice the LCX area, the tight stenosis was about 1.5 mLA, and the distal vessel was around 3.2, and the osteal L6 was 3.1. And left main, you have mild calcium, which is about from 12 to 3 o'clock. And the LAD opening, if you notice from the imaging point perspective, there was a significant calcium noted in the osteal LAD. So we wanted to do a IVUS of the LAD as well but our catheter could not track. So hence we used a small balloon to just track our IVUS catheter, and IVUS was done over here. And if you notice the calcium, as I mentioned earlier in the LAD as well, a significant amount of calcium, almost at 270 degrees, and the area was only about 1.5, and even at the distal left main, it was around 1.58. So again, the LAD reference distal was about 3. In view of significant calcium, hence we upfront straight away changed to use the microcatheter, changed our workhorse wire to a rotafloppy wire, and we took a 1.5 burr with a routine 1,65,000. After which we pre-dilated again with the same wire inserted, and definitely with the distal left main and some sort of calcium. Hence we used a cutting balloon in the LCX as well, and also in the distal left main at a nominal 12 to 13 pressure. Now, over here we chose to first stent the mid LED with a 2.75 and 34 stent. And over here the discussion was whether to think of doing which technique over here. Basically, we chose the left dominant because the size of the LCX was predominantly a big size vessel and it was more of left dominant system. Hence, we used the left main to LCX with 3.5 into 30. And what was done with the 4.5 into 8. And then the LCX was again pre-dilated. The wire was recrossed and again used it first 2 into 10 rotary balloon to open the and again the stent from the ostial 3 into 22 mildly protruding into the like a reverse trap. So the post dilated with 3.5 kissing was done at the distal left main, and again LCX and the distal left main kissing, which was noticed here. So this was the shot after a pot and then imaging. This is the LCX imaging, and if you notice the area, distal was about 8.8, MSA was about 7.3, and ostial LCX was 12.8. LED opening, if you notice some sort of area, was around 9.8, and left main was about 7.6. And imaging of the left main to the LED, we noticed the distal area of only about 4.5 and ostial of about 5.3, LCX opening was about 4.5 from this perspective. In view of distal LED being small, mild undersized, hence we again post dilated with a 3 balloon at a high pressure of 14 to 20. So this was the final shots of bifurcation of left main, and even in this view you can notice the TAVI valve, which is reasonably good. So this is the pre PCI on the left image, and on the right if you notice the post after a rota as well as a cutting balloon. So the discussion, obviously, the recent data which has also showed that most of the valves are feasible for coronary access, and non-feasible, especially it comes to evolute, which is about 9%. But if you take a balloon expandable valve, almost most of the coronary access is feasible. And coronary access after TAVR is always a challenge, especially it's the send frame interference, it's a commercial misalignment, and the other transcatheter valve skirt, which can hinder in accessing portions of patients. Again, the choice of valve also takes into consideration the shorter frame, especially SAPIEN or the My valve shows a higher success rate comparing to the tall frame self-expanding valves. Thank you. I'm
So a nice case.
sharing right.
Yeah, nice case, Ashish. Actually, a few things. Well, first thing is the question always why coronary first or TAVR first, and second thing is the choice of technique. You wanted to do a tap in the left main. Is there any reason why you chose tap as your technique for the left main bifurcation?
Basically, I wanted to make it a little simple and short over here because we are going to have a complex scenario. So, and I prefer more of tap technique. Some few cases I do DK crush, but it's mostly a tap. In this case, it was a reverse. Basically, I chose the left main to LCX as a major vessel and the LED as a branch vessel. And the question of again TAVI or PCI, there are two schools of thoughts everywhere. In this case, basically, he had exertional symptoms associated with syncope. He didn't have much of angina. So I preferred doing a TAVI first and even when you have an issue, we always have access. Even if anything happens, coronary can be tackled. When you're doing a coronary and if anything happens, we are obviously have a difficulty in that scenario because we won't have the valve on table and all those things. So here it's obviously decision depends which is more comfortable to you. So we prefer doing a TAVI first, followed by a PCI.
That's interesting because that's what I was also thinking. Why not PCI first? But anyway,
Coronary
even
can
the
always
experts will
be
say,
accessed anytime.
yeah,
if
but you
we can,
still say 2% out accessibility network as well.
no,
2%
basically,
chance.
why PCI? PCI can be done anytime. Even if you have any issue while doing a TAVI, you can definitely have a good inside. You don't have any issues accessing coronary, and you can definitely proceed faster. But when you are doing a coronary and when you have any issues, when you any slow flow, anything happens at that moment, you don't have the valve in hand with you, and then you get stuck up at that moment.
And also, when the iris doesn't go, you could have gone directly with the rota, valve. That's the
I
big
wanted to do
difference.
imaging, so basically that was the reason I thought, okay, let me do the
Just
imaging.
for the audience, like if it's simple, like you do IVAS, if IVAS goes the image, if it doesn't, it's rota. You would have to take more time. But great guess, excellent, well done, nice.
Yeah. Shankar sir.
Yeah, nice case, Ashish, as usual. But then again, I would beg to differ. I would probably handle the coronary first because it's a left main equivalent scenario. And I mean, that's the only thing I would have done differently, if at all. So we did encounter a similar case a few months back where I fixed the coronary first and then it gave me some leverage and it was easier. But then, yeah, we can always argue either side. Great case.
Thank you.
Congrats.
So if there are no questions, I'll call our second speaker, double vessel rota in a frail lady by Dr. Karthik Kanapiran.
Karthik, by the way, is a star of Coimbatore. Okay, he's doing a lot of excellent cases. You're not seeing a face, Karthik.
Is he there?
He was there earlier.
Yeah, I can see Karthik, but I'm not able to see his face. Is your camera on?
And he was sharing the slide earlier. What happened, Karthik?
Yeah.
Can you share the screen, Karthik?
As he gets up his slide, I just wanted to ask, what is frailty in the real sense? Because now uh, for surgeon, now they are also kind of lowering their standards of frailty. And for us, when we do complex intervention, then of course there are scores and indexes, but what exactly do you kind of do when you, is there a way of predicting that this patient is just by frailty that he goes to this particular arm? Sir, so what is your take on frailty?
Frailty.
Yeah.
I mean, PCI is a procedure for symptom relief. So,
Yeah.
frailty patients having a symptom, they need it.
No, that's okay. What I'm asking is, for we do all the scoring systems, isn't it? And of course, for surgery versus high risk PCI.
For frailty.
Yeah.
So it's basically it's more towards the functional assessment, mobility, and the assessment of the cognitive. Everything takes into the consideration in frailty index. So basically, especially in aged old people, you do have issues with underlying other comorbidities, or some maybe having neurological issues. So it's more towards the assessment of the overall perspective of the patient. So it's almost like an 8 or 9 point decisions in the frailty index.
Can you see my slide, sir?
Yeah.
Yeah, you can see, Karthik.
Yes, sir. Yes. So this is a 65-year-old female with no case of chronic diabetes.
The audio is not good.
Hello, sir.
Yeah.
Can you hear me?
Yeah, better.
Yes, sir. This is a 65-year female, a known case of diabetes and hypertension, uncontrolled diabetes. That's submitted with complaints of fever and burning micturition for 2 to 3 days of duration, with history of pain and dyspnea. And her pulse rate was 118 and the BP 80/62. Her ECG showed ST depression in V3 to V6. Echo showed regional wall motion abnormality in LA territory and L6 territory. And she had moderate LVD. And tropoy, we did tropoy. Tropoy was highly positive. So her total counts grossly elevated, and her urine showed plenty of pus. Creatinine was 1.7 milligram per deciliter, and she was treated with IV antibiotics, noradil infusion, DAPT in view of elevated troponin, and other acute coronary syndrome measures. And ultrasound showed no evidence of complicated ATA. And after 2 days, she improved, and her BP stabilized, and creatinine came to 1.4. So it's a case of uncomplicated UTI with septic cardiogenic shock, non-ST elevation myocardial infection with moderate elevation. So after that, we decided to study her, and this is the angiogram. Angiogram showed left right coronary artery, right dominant right coronary artery with significant stenosis in the proximal RCA, 60 to 70% stenosis in the proximal, 70 to 80% stenosis in the proximal RCA. And this is the left side, and you can see and significant long segment calcified lesion in the proximal LAD, extending into the distal, extending into the distal LCs. And LAD, you can see a long calcified lesion in the proximal LAD. So, in view of high syntax score and significant fluid disease, we offered the CABG, but the patient go under the knife, so as well as the family. So they opted for multivessel PCI. So we decided to tackle the L6 first. We left with jail catheter, rota, but we decided to proceed, and we were stuck here. So, in spite of repeated attempts, we couldn't cross the lesion in the proximal LC. So, due to improper coaxial alignment of the guide and acute angle of LCX, and significant critical lesion of the LCs. So we had a very tough time to cross this lesion. So we were doing just picking, and in each and every advancement of rotor burr, the catheter was constantly backing out. There were no good support with the catheter. In between, patient developed hypotension and angina, so we had to start noradrenaline infusion, and in between we have to stop the procedure and had to give adequate time for the coronary artery. So after this picking, slow, constant picking motion, finally the lesion gave away, and we could able to cross that lesion, and we crossed the rotor burr into the blood.
I think while Karthik's video is loading,
Yes, sir. There is a problem with my PowerPoint, sir.
That's okay, Karthik. Take your time. I think I'll start some discussions here.
Yeah.
The problem lies here is the guide support. That's a big issue. Judkins actually doesn't give good support, as you all know, especially for rota when the lesions are tough. Guide support is good, and also the bend in the Judkins doesn't allow the exit of the rota burr sometimes, especially when taking 6 French. 7 French you can manage slightly, but 6 French you have a very difficult time to get a 1.5 burr across the distal, the last curve of the Judkins. So backup catheter is always better because of delivering of that rota burr, whether it's 1.5 or 1.25, 1.75 either. Yes, Karthik, you can keep loading it. I'll just. So when you are doing rota, always take a backup catheter if possible. Only it's a situation where you have a very severe osteal disease, where you may have difficulty in edging. But there, what you can do is you can downsize the backup catheter there and then have some iodorsal wire for little support, and with disengagement sometimes helps. So a backup catheter definitely is a first choice, it should be first choice for the rota cases. What do you think, Dr. Karthikeyan?
Yeah. Actually, rota by default to 7 French guiding, good support. And also here, I think probably the idea was to do both the vessels, so probably it was a 1.5. Maybe if the LCX had taken a 1.25, probably it could have probably gone a little bit earlier without much difficulty.
No, I think it's the guide which is pushing a lot of back force. Rather than advancing, it's pushing the guide out. So, and 1.25 always it's tricky, isn't it? It just jumps in and then it gets stuck.
Yes.
And,
in fact, if you look at stuck burrs, it's always 1.25 which gets stuck. It's not the 1.5.
The shape is bullet.
But the shape is like that, the shape is not the typical clover shape of a larger burr. This is really literally bullet shaped only. So that but sometimes, when here I think the thought process would have been that both the vessels rota would have been the idea. So 1.5 would have been a single burr for both vessels.
But the amount of calcium looks a lot. Sometimes may have to take 2 burr, like you said, I think Karthik's laptop has a problem.
Yes.
Let's see. The next speaker ready, or we can how do you think? Do you think you can fix it, Karthik, or?
Yes, sir. It's sir, can proceed with the next speaker, sir.
Yeah. What we'll do is we'll kind of continue back after. I'll get.
If Praveen is ready, is he ready? You can just ask.
Yes, sir, I'm ready, sir. Can you
go with, yeah. You share your slides.
Can you unshare your screen, Karthik?
Yes.
So a calcific left main trifurcation.
Bifurcation.
Another star from Coimbatore. Praveen, great.
Everybody from Coimbatore is a star, DMT.
Yes, sir.
A corollary to your statement. So,
Praveen is a rising star.
I was sort of sleepy and suddenly I heard this comment and I woke up.
So are my slides visible, sir?
Yeah, it is.
Can I start my presentation?
Yes, go ahead.
Good evening, respected chairperson. I'm going to present a case of calcific left main bifurcation. This is my case, a 63-year-old male, diabetes on treatment. He was admitted with complaints of chest pain for the last 5 days. ECG showed T-inversion in anterior leads. He was admitted in an outside hospital. Troponin was positive. Echo showed hypokinetic LAD territory with an ejection fraction of 45%. He was given heparin antiplatelets for 2 days, and after that, angiogram was done. It showed double vessel disease of LAD and LCX with calcific coronaries. So he was advised CBG bar multivessel PCI. After that, he was admitted in our hospital. The outside angio was not having proper quality. So I'm presenting the angio taken in our hospital. So it was a double vessel disease of LAD and L6. We thought of going in for an IVES plus rota-guided PTCA to LAD and L6. So we went with the 7 French EBU 3.5 guide with femoral approach.
The slides are not playing. Videos not playing. Yeah.
Yes, sir. No. This was the angiogram in our hospital. Left main mid part showed some eccentric plaquing. LCX proximal part showed some 40 to 50% diffuse disease with a major OM showing 90% lesion with calcification. And LAD proximal to mid LAD shows long segment diffuse disease with calcification, and a small size diagonal was seen. So we thought of going in with the IVES guided interpretation of LCX and LAD lesion, and if needed, a rota guided PCI or a cutting balloon guided PCI. At this point, my strategy was going in for an LM to LAD stenting and image assessment of that major OM, and I thought of going in for an depth to the major OM if the L6 ostium was not significantly diseased. At this stage before imaging, my strategy was LM LAD provisional stenting with an optional depth to OM from this ostium. And if L6 ostium was not severely diseased, I thought of leaving the L6 ostium. Initially, I did IVS assessment of LM LAD. So I'm showing my mouse to show the co-registration aspect. Distally, this was the landing zone as per angiogram. And after that, there was some 2-quadrant calcium with concentric lesion. And close to the diagonal branch, there was some diffuse disease with 2-quadrant calcium, and just above the diagonal branch, there was some 360-degree calcium in the IVUS, as we can see, followed by 2-quadrant calcium with a relatively larger size vessel of around 3 to 3.4 size vessel. And this is the bifurcation and the carina showing significant distal LM disease with calcification. These were the IVUS images. The distal landing zone showed 2.5 mm lumen, and the proximal landing zone showed a relatively disease-free area in the left main with the 4.5 to 5 mm. 5 mm was the vessel size and 4.5 mm was the lumen size. And here there was 360-degree calcium just above the diagonal, and the MLA in the LAD was 3.8. So at this point, our strategy was going in for a rota-guided PCI to LMLAD. Cutting balloon was out of option. After that, IVUS assessment of LM to L6 was done. This was the IVUS run of the LCX. So the starting point from distal OM. Here, as the IVUS was pulled at the tightest point, we can see some 2-quadrant calcium with significant shadowing. And here, at this point, we can see the L6, which was joining the OM. After that, there was some significant calcium in the 6, which was relatively not significant angiographically. And at the L6, there was significant disease with calcium. These are the still images. Here we can see the MLA of L6 ostium was only 3.25 with significant 2-quadrant calcium. The distal landing zone was 2.5. And LM we have already assessed by LM LAD pullback, and the current also showed some significant calcium. So after imaging, my strategy changed to mini crush bifurcation technique because there was significant calcium at the carena. Also, the L6 ostium had an MLA of only 3.25. So I thought of going in for an mini crush technique for this case. Initially, a 1.5 rota bar was taken, and after 4 runs, the tightest point in the mid LAD after diagonal was crossed at 170,000 RPM. And after that, polishing run was done to the LAD. The proximal LAD before diagonal, this area, has a 4 mm vessel, and we had to take only a 1.5 mm, but because the distally the LAD was a very small sized vessel. So I created an intentional wire brace by pulling the wire, and I did 140,000 RPMs so that to get a better luminal gain. After that, the rotor wire was exchanged to a workhorse wire. Distally, I did a 2.25 by 10 mm SC balloon dilatation, and proximally, I did 3 by 12 mm scoring balloon for the proximal tight portion where the LAD size was 3.5 mm. So after scoring balloon and NC preparation of the LAD, I went in for preparing the LCX. LCX was prepared with 2.25 distally because the aux scoring balloon didn't cross. After that, I did the 2.75 by 15 mm NC balloon dilatation for the L6 ostium. It was not yielding. So later, a 3 by 12 mm scoring balloon could crack the calcium at the L6 ostium. Distal LED stenting was done with 2.5 by 33 mm disc. Stent balloon was pulled and flat. I did post-dilatation with 2.75 mm distally and the 3.5 mm over the overlapping part. After post-dilatation of the distal LED stent, I took L6 stent, 2.5 by 32 mm L6 stent, and balloon was placed in the LED for crushing. Two studs were protruding into the left main. It was almost more than 90 degrees, so it was almost like a tap. The L6 stent was deployed. The stent balloon was pulled and flat. I usually do a post-dilatation of the side branch before crushing because mostly the ostium would have been not opened properly, so the recross will be difficult most of the time. So I finished the post-dilatation of the L6 stent before crushing it. I did post-dilatation with the 3.5 by 15 mm balloon. After post-dilatation of the L6 stent, I crushed it. I did the pot crush with 4 by 12 mm NC balloon. And after that, LM-LAD crossover stenting was done by 3.5 by 33 mm disc. So after LM-LAD stenting, there was good flow in the LM and LCX. After that, I did the 4 by 12 mm NC balloon dilatation for the LAD, followed by a 4.5 by 10 mm NC balloon dilatation, pot with the 4.5 by 12. After this, I did the non-distal cross. Initially, a 2.5 by 10 mm balloon was used to open the struts, and the kissing balloon inflation was done with a 3.5 in L6 and a 4 balloon in LM-LAD. After that, an IVUS assessment was done only to LM-LAD. This was the IVUS run of LM-LAD. The stent has not yet started. And here comes the stent. Distally, there are no edge dissection with a well opposed stent. A well opposed stent and showing good expansion. This portion is near the tightest point where we did the cutting volume inflation near the diagonal ostium. Here we could achieve an area of 10.2 MSA. And we are almost close to the bifurcation. Here was the bifurcation with the side branch wire. And this is the LM part. In the LM also, after a 4.5 balloon pot, it is well opposed stent. Sorry, this is the bifurcation, and this is the LM area. Sorry. And after a pot, the stent is well opposed to the left main. And proximally also, it's well opposed and no edge dissection and proximal edge dissection. The still image of the IVUS run, distal LAD shows good area, good apportion, no edge dissection. The MSA in the distal LAD was 5.2, and proximally in the tightest portion, we had an MSA of 7.5, and the LM stent is well opposed to the wall. This is the cranial as well as the caudal shots after the IVUS run. And this is the pre and the post shots. We could achieve good areas in the left main and LAD as well as in the circumflex. It was a calcific coronary both in LAD as well as L6. L6 we could achieve it with a scoring balloon. LM LAD we did the rota, and finally we ended it with the mini crush technique. Thank you.
Very well done, Praveen. Excellent case. Just 2 or 3 comments. When you're crushing the stent, try to avoid keeping the wire in the thing because you can crush the metal over the trap wire. There is a possibility that wire can get trapped because you won't take it anyway. There's no need to because you run a good dilatation. Recrossing will never be an issue. So try to avoid a wire when you're especially crushing that stent because it sometimes can cause trouble. And you didn't come to the ostium of left main, isn't it? You just stand at a proximal left main, isn't it?
Yes, sir. Yes, sir. LM actually angiographically showed some eccentric plaquing, but that area, the plaque burden was less than 20%, sir.
I would, because it's extremely clean vessel, you better come to the ostium. It's always safer. You don't have to have too much hangout of the ostium, but at least just landing at ostium will be best because you never know. I had a few occasions, you think it's a perfect landing, you got little plaques, but to come back to the ISR. It can happen, especially when you're doing post-dilatation aggressively. You always traumatize a little bit of the proximal plaque. So better like if you're coming left main, okay, if it is very long left main and you're going to cover another 20 mm, 15 mm, then it's okay. But if you have another 4 5 mm, better come to the ostium. That's my suggestion.
The second thing is when we're doing left main to LAD, this especially with a lot of size difference between the left main and LAD, and we do distal to proximal post dilatation, the stent tends to elongate. So you think you have started in a good place, but then the stent would have elongated. So like sir said, it's better, and also you know when you're doing your post dilatation, better to come from proximal to distal so that your elongation is a little bit less. That's something because now longitudinal stent elongation is a definite entity, and especially when you are malapose in the left main, and when you come from distal, and also depends on the number of post dilatations you are doing. The number of dilatations you do from distal to proximal, the stent elongates more. That's something when you're doing crossover. And second thing is you're post dilating the circumflex ostium and then crushing. See, if you can go with your your stent balloon to high pressures, because you don't want any scuffle happening later, because anyway you have a balloon in, but then once you do high pressure post dilatation, and you have a lot of metal which is crowding in the, and then you have to do extra effort to crush the protruding struts. And here your final thing. If you look at your spider, the ostial circumflex area still looks little compared to the smaller compared to the proximal circumflex. Probably did you do I was run back to the circumflex because the areas in the circumflex are determinant. And also preparing, when you want to prepare, scoring balloon is good, but then once you are dealing with ostial circumflex, it's better to get, because at the end of the day it's just in a wire, so you can do a cutting balloon and get the circumflex well prepared, and then you will save a lot of hassle. So the end result looks very pleasing and very nice. But these are small tips and tricks when you are doing this, because the strategy has changed after your IVAS. So when you have something in mind and then go in and then your IVAS changes your thinking, then our hardware thing on the shelf also is important. But then I would have prepared the circumflex well with cutting, so that that will not be the scoring balloons. End of the day, in a calcific vessel, in a fibrotic plaque, it's fine, but then in a calcific vessel, scoring is end of the just a wire. It's like post-focus dilatation. So calcific or fibrocalcific cutting balloon may help. So that's something. But at the end of the day, it's a very nice end result. And keep the patient on. Whenever you do left main bifurcations and long lens, always sound the patient for a check angiogram at some point of time, so that you will know your results, and also if something is happening, you can pick it up early also.
Yes.
So, sir, Jaishankar sir is Dr. Jaishankar sir, is he able to hear us?
Sir, can I share my doubts, sir, actually, regarding this patient? Sir, when the IVAS run was made for the LAD, I could see that there was some reverberation in the 360-degree calcium.
Yes, yes, yes.
So probably if we could have, that might be because of thin calcium. Probably we could have get away with the cutting balloon there, or
Yes.
was there rota was absolutely necessary there, sir?
See, when you see reverberation artifacts, it's thin calcium, yes. It is a balloon-based strategy may work, but probably the thing is, if we get nasty dissections after your balloon-based strategy, then you can't advance your rota, especially when you go into high pressures. Probably because of in totality, the vessel looked bad, and but when you see reverberation artifacts, that's indication of thin calcium, and balloon-based high pressure balloon strategies may work.
You definitely could have got away with the balloon itself, but problem is you will get better result with the rota, because even the extra calcium preparation, especially like slightly smaller vessel like 2.5 vessel, even little extra 0.5 square mm, 0.1 square mm makes a difference in long-term outcomes. So anything is an add-on. So I would suggest, yeah, definitely you could have got away, definitely, but this gives a better edge. You combine this, and then you high pressure pre-dilatation or cutting balloon, then you get a much better lumen. Because you can't do it after stenting, and then it becomes difficult. Then you may have to go for IVL and things. At least you do upheld. That helps.
Karthik?
Yes, sir.
Hello, Saravanan, can you hear me?
Yes, Vijay, we are hearing you now. Yeah. Welcome.
The reverberation, is not always thin calcium. So that's why they removed from the calcium score. You remember the old IVAS calcium score reverberation is one of the indicator. But the recently, even about 30% of the cases, even you have reverberation, it is thick calcium. So it's not always thin calcium.
Not only that, density of calcium is something we can't really predict only by our intracoronary imaging. So the density of calcium also matters actually. And when we do cardiac CT, we are really appreciated much better. And IVAS has its own, because of its lot of, after the arc you will have only a shadow. So the density of calcium is something we only assume. So that is also there. But always rota gives you that better preparation. And also when you do run with a little lower speed, it gives you better lumen area when you cruise along. One is pecking, and also Japanese operators do a little bit of cruising at lower speeds, so that gives you better lumen gain also.
very, very nice case, nicely done case. Yeah.
Thank you, sir.
Thank you, sir.
So probably if Karthik's is ready. Karthik's ready with his.
Sir, can I keep my presentation at the
Yes,
last?
of course.
Till I'm
Yes.
voting
Okay.
in.
Okay. Then I will call Dr. Mohammed Aziz to present his case of zero contrast PCI.
Sir, good evening. Am I visible, sir?
Yes, yes.
You can share your slide, Dr. Aziz.
Yes, sir. Sir, are my slides visible, sir?
Yes, it's visible.
Okay. So good evening to one and all present here, sir. To my special mention to the expert panelists and chairpersons. So my case here is zero contrast LMPCI in a tertiary care center. My patient is a 55-year-old gentleman presented with is a known CKD. The creatinine is around 2.6. EGFR was calculated to be 25, diabetic. Presented with anti-reval MI, which was evolved when he presented to us. With moderate LV systolic dysfunction. So I planned for a angiogram. So this was an angiogram for the patient. So with the minimal contrast, there was RA cordial view showed a ostial LAD significant lesion with an ectasia following the lesion, and this is a RCA image which showed a mid RCA lesion. Angiography, it was about 60% to 70%. So I wanted to do an image, then plan on whether to do RCA along with LAD. LAD ostium was not healthy angiographically. There was a plaque there. Distal LM was tapering, and ostial circumflex could be visible as a So ostium circumflex angiographically seemed okay. So before I could start, I was thinking about a zero contrast PCI LMLAD with an imaging guidance. I thought of doing a LCX IVUS also to see the ostium, whether my strategy would change or not. So then I proceeded after 2 days, the creatinine stayed normal. After getting a nephrologist clearance, I went ahead with PCI. So it's just any contrast there. So of the LAD was done in the RAO caudal view using Orcos wire, and LCX was also wired. And LMLAD I was this. So in the ectasia segment, there was following the extraction, the lesion was very significant there. It was only about 3.2 and block burden was 81. This is the left main. Left main was okay, but there was some fibrous block, so I had to come till the ostium. So what I did was played the IVUS, placed it at the ostium, and made a cine, which I recorded on the still image on the right side, and on the distal vessel also I took a cine and recorded it. So that my length of, the proximal and the distal landing was angiographically available there. Then this was the reference diameter of left LAD, the ectatic segment. I wanted to land there. It was about 5 there, and LM was also 5. So LCX ostium, was done. Ostium was not significant. The lesion, there's no plaque there. This is the ostial LCX. LCX was okay. The angle of the LM, LAD, and LCX was 90 degrees. So I went ahead with the provisional LM LAD strategy. So this is the LCX ostium. It was 9.24 millimeter square. So I initially, since the LAD ostium, we could see there was a fibrofatty plaque there. So I thought we could get away with a scoring balloon. Cutting balloon. I wanted to use a cutting balloon here because I didn't want to make a nasty dissection there, so that which would make me use more contrast. So I didn't use any contrast there. So I had to downsize the cutting balloon to 2.75. Even though the vessel size was ectatic, I just wanted to make some cuts there to make a better lumen and stent it. Then I would go ahead with the post dilatation. That's what my plan was. So I took a 27510 cutting balloon. Post cutting balloon, there was some lumen gain there. Sorry. Just a minute, sir.
So, as you get up your slides, I will take
Yes,
this
sir.
opportunity to welcome Dr. Madhavan, our moderator, expert panelist from Madurai. So, welcome, sir. And as slides working, we can continue.
So may I continue?
Yes, yes.
Yes, sir. So after doing a pre-dilatation with the cutting balloon, then post IVS of the after pre-dilatation was done, and it could show there was not a significant cut, but there was some lumen gain, and there was no nasty dissections there. So I thought since it's a fibrofatty plaque, I went ahead with the stenting of LM to LAD. So positioning, as I mentioned, initially recorded that ostial marker as the, I mean the IVAS marker as the ostium and the distal marker as IVAS marker as the distal landing zone. Then the length was about 20 mm, so 420 DS was deployed from LM LED, and after that 5 8 LM pot was done, and LAD post dilated with 4 6 non-compliant balloon. And after post dilatation, after pot and post dilatation, I repeated IVAS of the LAD. Could see the LAD distal stent had landed. The stent had begun in the LAD now. This is the ectatic segment, and the ostium. This is the ostial LAD. Circumflex has come. Ostium looks better. Circumflex ostium is open as per this view, but I had to make sure left main ostium was also covered almost. So, so this was the area in the distal LAD on the left side, and this is ostial MSA of about 10.6 in the LAD, and the LM area was also 13.6. So I think the LM LAD job was done. Then the next thing I wanted to do was rewire the L6 and see the ostium of the L6. Patient was clinically stable throughout the procedure, no ECG changes there. So L6 ostium, this is a OM there coming, and this is the LCS ostium. There was some plaque in the ostium, but I think it was not on the the area was about 8.9 there, near the ostium. So this I had to take a final angiogram just to show the attenders, because I am this is a third tier place, so I had to show them. So I took a 2 ml diluted contrast angiogram, and this was the final result. So after this, I took a JR catheter and I did IVAS for the RCA. The plaque there was 4. The MSA, I mean MLA was 4. So with the plaque burden of 59, so I deferred the RC angioplasty. The patient was stable and got discharged.
Very nice case, Dr. Mohammed Aziz. Excellent. I don't have to be very obsessed with the zero contrast, because that's always we get very fancy about zero contrast, but safety of the procedure comes first, because at least I don't claim to be zero contrast, but at least for stent positioning, and sometimes you may have to use it. You never know, because you do one little mistake, you may have to put one more stent or something, and that costs more, not that long-term implication than another 2 ml or 4 ml contrast. So it's okay. We have done very well. I think could be flawed from this, but it's perfect. But I've seen people getting in trouble just doing zero contrast and wiring a parallel wire into the thinking it's a LED and going to parallel circle and doing something in the circle. It just sometimes just at least one picture before stent positioning is what I would normally do. And
actually,
it's done very well. I don't think it's perfect. But you don't have to be very, very this thing about, because renal impairment most time is CKD, I work in one of the largest transplant centers in India. So where we do lots of patients with stage 4 just before we can not having dialysis, but on verge of it. Most time we get away. Very rarely, very not. I think only once I had a patient who almost went for dialysis from 1.6 creatinine went to, that was a very complex, big procedure. He went to almost like 5, 6 creatinine. He refused for dialysis, but then it started coming down again. So that was one close encounter, contrast nephropathy after many cases. So I would worry too much about little contrast. You will get a, because your diagnostic angiogram didn't have any creatinine raise. That's one indicator saying that you will not have a creatinine raise. If you had a, for example, if you had a creatinine raise of very bad, then you're definitely justified using zero contrast and things. But you've done very well. Look, I'm not saying anything, but my lesson to the listeners is don't get too obsessed about zero contrast, safety of the procedure. I keep saying complication of angiogram is not doing it properly. If we don't do it properly, we have to do it again, and that's more complex than the complication of the procedure itself.
Very nice comments from sir. Actually, to add a little bit, ultra low contrast PCI is something what we can think of, because there instead of absolute zero, because the march towards absolute zero is always what with a little bit more problems, because we are working little blinded. And second thing is final angiogram is always important, because distal wire perf you cannot pick up with your IVUS. So the distal wire position, no, always somebody has to watch. And we have seen cases where good zero contrast PCI, but then distal wire perforation. So it's always good to have a good final shot, especially here. Your caudal view is good, but then a cranial view, because that's where the IVUS keeps going so many times in and out, and your distal wire position. If you had gone to a small branch, and God forbid that something would have missed. So good final shots to see the beginning of the vessel, beginning of the stent, end of the stent, and end of the vessel. All four has to be documented in your final angiogram, so that 2 to 3 ml of contrast, diluted contrast, is not going to harm. And like when you're doing left main to LAD, positioning, when you want to do, because you know, precise ostial positioning, or you're going to come a little bit into the left main, and then looking at stent elongation, because it's a real thing. 10% elongation can happen depending on the brand of stent you use. So it's always good to have a little bit diluted contrast, and ultra low contrast, at least the amount you calculate EGFR and then take a call. But zero contrast, when you're doing it has its own little bit caveats, like what sir has said. But then the final angiogram, to show that you don't have a distal wire perf, is very important.
While we're there, what's about mixing, like mixed contrast and diluted, non-diluted contrast? I have this kind of little concern about undiluted contrast, because we tend to inject more undiluted contrast than sorry, so I tend to do mixed.
I agree what you're saying.
You inject more to get a picture.
No,
rather you could use undiluted, give a little injection. What's your view? Because I tried a 50-50.
It all depends
where you go to a full contrast with a little injection.
What I was trying to say is that here you're going to do only proximal for positioning and all that. No, you really don't require that dark thing. But when you take your final shot, you're looking at distal wire perf. That is where you want to give your proper, a good magnification, and then because for that you need your proper contrast, and because that's something we don't want to miss. So it's just that for what purpose we are using. So that because we save on contrast, because I always EGFR is calculated. I know what my limit is going to be for that particular case. So when I'm crossing that limit, then it becomes I start even before I start diluting, and because for small puffs for positioning and all that, I don't think you need to take those. But the last shot should be really good to show a document for posterity that we did a clean job.
But very well done, Dr. Mohammed Aziz, because
great, nicely done.
You're doing it, because sometimes when you're doing in a non, sorry, the diversity, and then you have issues and things, a lot of implications are there, isn't it? But you've done very well.
Yes.
But it's a very good case.
Yeah.
Okay. Thank you, sir.
Yes, Dr. Karthik, ready with the slides? Karthik, slides?
I think we'll go for next speaker then.
Dr. Madhavan sir is, I don't know whether he's again, he's here. I don't know, I'm not able to see him on the.
So can you see Madhavan sir? Because he was.
I saw him transiently, and then I don't know. I don't see him now.
I think we are
Fine.
again.
So there are two more presentations, Dr. Karthik Kannibaran sir and Dr. Karthikeyan. Karthik was.
Dr. Karthikeyan here.
No, sir, he was in he got stuck in a primary in Miluppuram. I'll just check with him. He was supposed to join by 8 o'clock. I'll just check with him.
Okay. But otherwise, we'll look at Karthik Kannibaran's case because we were halfway through the bird which was struggling to cross the LCX.
So what would be a strategy when you're having difficulty in crossing? Sometimes I think the bird time, if it is more than 4 or 5 minutes, 5 minutes is the time when it loses efficiency, start losing efficiency. And I think most of the time it will almost be near of that last bit and it doesn't cross. And sometimes we waste another 2 minutes, doesn't cross. So I think that's where we take a new bird, which goes within 30 seconds, just like that.
Yeah.
When the longer bird, when
Yes.
they get stuck in that bird, then it doesn't cross. So when the bird is not crossing it long, then if the budget is not an issue, we should go for the next bird.
True.
And suggested if it is very, very tough, severe calcium, you grade by 1.25 and then upgrade it. That's not a choice we have.
I don't know, both the speakers are not available. I was Sridhar, can you just check with Karthik what's happening?
This new rotor wire is very good, isn't it?
Yes, a new rotor wire is that's a good wire, and
but they're charging 3 times more. So I use only 50% of time. If I have only, it is not so bad torture through and I use the normal wire. I still got used to that.
See, the floppy wire is still, you know, the most commonly used wire. But then, but most of the time, no, it's going with a higher French guide and supportive guide. That gives you that thing.
Other thing is, when we have difficulty in wiring, when you're doing for example, using a microcatheter exchange, the microcatheter can go in the distal and then exchange. You better go with 1.5 than 1.25 because 1.25, I mean, if a microcatheter can cross a lesion,
yes,
better go with 1.5.
Yeah,
it's a little bit.
Yeah, that's equivalent to a 1.5 balloon crossing. That's why even in CTOs, when we cross with a microcatheter, we always take a larger balloon for
exactly.
Okay. So if our presenters are not there, probably I'll share my screen. I'll show you show a case where,
yeah, that's a good idea. Why not?
Where just to show the difficulty with crossover stenting. Let me just see whether I can. So this is a case which I thought, because always when we're doing left main, which I showed in India Live, probably I'll just show this. So this was, can you see my slides?
Yes, yes.
Okay. So this was a 54-year-old male. He had single vessel disease and he presented with evolved anterior wall MI. So the idea was to do IVUS guided PCI left main to LAD after. So this was the lesions. Let me just play it. So it was, you can see that some distal left main. I thought we'll do LM to LAD. So two sequential lesions. And so this is, I've just enhanced it digitally for, so I just did a pre-dilatation with a 2.25 mm balloon. And then the stent length chosen was 3.5 into 44. Why this is important, I will just let you know. I just stented 3.5 into 44 and post-dilated with the 4 mm balloon. And LM pot was done with the 5 mm balloon. You can go through this IVUS that the left main is a very nice vessel. The ostium really need not have been covered. So I thought I will just cover from the mid part of left main. So this was the procedure. And you can see that how the stent is actually positioned. And you can see that the stent is actually here in the mid part of the left main. And so post-stenting and first optimization, we note that it's a well-apposed stent in the LAD with good opposition. And then there's mild malapposition in the left main. So the stent is started in the shaft of the left main. And the ostium of the left main is not covered by the stent. And the stent length has increased by 3.5 millimeters in the longitudinal display. This is very important because I started with a 44 millimeter stent and it's now 47.45. This is very, because whenever we do this LM to LAD stenting, it's a good practice to see what is your stent length after your post dilatations. So this is the post stenting and first optimization. I can go back to the slides and I'll just show you the, yes, you can see that this is the length after the, and this ostium, I have not come to anywhere close to the ostium. And so this is your IVUS run. And then I thought I'll do further optimization with the same balloon at higher pressure. So this is good areas. This is not the problem. So as you come towards the left main, notice that how the stent is behaving. You can still see the stent. And I was actually presently surprised. You can see this. Now you can see that there is no stent here. I'll do the next post further optimization. And this is what happened. So this is the stent. You can see from the left main what is happening to the stent. Yeah. Now you can see that stent has come all the way to the ostium. And the total stent length was 52. So this was the final, the images looked good. I didn't do anything more. So the IVUS run findings post for the optimization showed well-opposed stent in LAD and LM with good areas. The stent is elongated in the shaft of the LMCA and ostium now covered by stent struts. The stent length has further increased by 5.3 millimeters in the longitudinal display, and the total longitudinal stent elongation was 8.78. So this is the thing. So the sequence of post-dilatation is very important. So be aware of longitudinal stent elongation when using long size stents, especially when there's a significant mismatch between the proximal and distal landing zones. and when extensive post-dilatation needs to be done. And more relevant when extensive pot is done at higher expansion limits of the stent. Stent design, sequence of post-dilatation, length of post-dilatation balloon, and the number of high-pressure dilatations may have a role to play in this phenomenon. So this is something I wanted to share because this is Rover's session, and we are having a lot of left mains. So I thought I just a small word of caution. So I close my presentation, and
it's definitely nice to keep knowing this, because I kind of by default strategy nowadays is not to take a long stand. I land in the proximal and put a Megatron from ostial to thing, because Megatron has got a big thickness and it goes really nicely. So I'm quite happy. Although it's hello, Dr. Madhavan.
Hi. How are you?
Good evening, sir. Good evening, sir.
Good evening.
Nice stand, Megatron, because what do you think about Dr. Madhavan, Megatron stand? I'm a big fan.
I have not used Saravanan, but this stent elongation I saw yesterday in one of my patient. So we have seen a lot of LST in Bromus element. But
I think it
stent
happened
elongation I saw in Abbott stent.
All the stents, when like Dr. Karthikeyan said, when you keep stretching, it stretches a lot. I think the best thing is not to overstretch the stent, which is designed. For example, a 2.5 stent, if you go to 3.5 to 4, then it completely distorts some things. So my suggestion is like split it into two. And now stents are cheap.
Two stents.
Two stents. Rather than one long stent, two stents. Then you can go appropriately. For example, if a left main 4.5 and a 3 of mid LAD, you can go with a 3 to proximal and then a 3.5 or a 4 from the left main to the ring.
No, the reason
that makes a difference.
I thought why I wanted to show this is that 10% of stent elongation is mostly there. If you go through all their manufacturers, internal documents, 10% longitudinal stent elongation is there. But sometimes we do get more because the initial stent, when you do a crossover and the left main is large, the stent is obviously malapposed. And then when we are going to do post dilatation, the stent has got two dimensions in which it expand, both in the radial and longitudinal plane. So the number of dilatations we are doing, the stent keeps on elongating. And it's okay when the left main is not diseased and the radial, it's not that bad. But then if left main is diseased, then the radial stent will get compromised as we keep on stretching. So that's the thing I just wanted to, because we have seen extreme longitudinal stent elongations also. So that's something I thought I'll share, because a small warning. It's with every stent. It's not that a particular brand or.
I think it's described for almost every stent.
Yes. When you do imaging, I think our colleagues from Meenakshi, they had a large series from 30 cases they had done OCT and they had shown. So it's not unusual, but I think it's better to be aware of. In fact, Dr. Saravan's strategy of splitting it into two makes better. And of course, Megatron is very nice, but the longest length they have in Megatron is, I think,
it's only 32 or something. It's not,
32. Yeah, it's not. They don't have a long thing.
No, it's mainly it should be just a proximal landing, and then you can walk in the proximal area in the safe area.
Yeah.
And then now every company is claiming that we can use 3.5 stent, go and stretch up to 5.5. No, it doesn't work out that way, no. Even yesterday's mic was picked up by OCT. Because all these years we are worrying about the LSD only.
Yeah.
When the stainless steel.
Thanks, Karthikeyan, for sharing your experience on these things. The take-home message is try to choose two stents when there is a big discrepancy between the proximal and distal landing zones.
Yeah. And other thing is your post-dilatation sequence also is important. So we have always been doing distal to proximal. But when you are doing a crossover, it's better to do proximal to distal. There's proximal, distal, and then middle. That is in bench testing as shown to have reduced longitudinal elongation. Because once you fix the proximal and then the distal, the stent is not going to have any freedom of movement in the longitudinal plane.
Okay.
Then you can do your post-dilatation peacefully. After this case,
especially Australia.
Yes.
We fix and
so almost the left main thing, once you're done it, you're just going to do a pod immediately. The
Yes.
part immediately, the first part, I think it's rather better. Like if you're just landing at the ostium, better fix the ostium. Then
Yes.
sometimes when you're just short of ostium, you want to cover the ostium, then you can little cheat by doing distal and come back to the proximal. Then that cheats pushes the
No,
slightly up
this
there.
is very important when you do ostial LAD stenting. You would have got the ostium, and then after your post dilatation, the stent will be in the polygonal
Exactly.
planes.
You're right. It's like a crossing of the circumflex.
Yes, yes. So that is also happening. That's why I thought I just bring this phenomenon, shows this is a real nice imaging example. So I thought I show that. What
Doesn't
about
happen much in the stainless steel stent because stainless
Yeah.
steel doesn't elongate like this. They break. This.
True.
It's all this cobalt, chromium, cobalt, platinum alloy. They just stretch. They don't break. They just stretch along.
Yes. Only stainless steel we have right now is biofreedom, I think. That also they are coming up with the ultra, which is cobalt chromium. The original biofreedom was actually stainless steel. Sridhar, what about our speakers? Are they ready?
So Dr. Karthik Kanabaran sir was there. Suddenly, I think he just left now, and we'll just check with him.
Okay.
But while trying to reach out to Dr. Karthikeyan sir, he's still in the primary. It may take another few minutes then. Apologies for the delay.
Okay. So another thing when I wanted to ask our expert panelists, see when we were previously this precise ostial stenting versus crossover, is it now a done deal that you would do only crossover, or when would you do precise ostial stenting?
No, mostly crossover because the size is not a too big issue. But there may sometimes when the size of left main is 6 mm.
Yeah.
And you can never match the 6 mm. There, I think we might have to have one step outside and then we have to take a chance. Otherwise, other than that, 5.5 mm, you can always cross over. But if it is a very, very huge left main and there you cannot cross over, then I think you mostly crossover because you never, after like the same like what you're saying in the elongation, you precisely end up in the ostium, post dilate the left main LAD ostium, and you see the steps right across circumflex and you have to take a funneling out and take. So rather you do electively a crossover much easier.
Yeah. In fact, when you are forced to do ostial stenting, sometimes that it's also good you to have a guide extension. Now we have one wire in the circumflex, one wire in the LAD, and then you use the guide extension. So that guide will not move beyond the carina, and then stent. Sometimes it works. You have a really good.
Can you elaborate that, Karthi?
Actually, it's like how we those days, there was this technique, where you would take the stent and then put this wire from the circumflex onto the stent and then recrimp it. Instead of doing that, what you can do is have a guide extension, and you have one wire in the circumflex, one wire in the LAD, and then when you load the guide extension, you load with the two wires, so that the guide extension will go all the way and it will stop at the carina because the two wires are there. It will not allow the guide extension to move beyond that. And then you take your stent on the LAD wire and then stent it.
So you may need to take a bigger size guide extension, or you're okay with the same?
Yeah, your extra lumen guide extension should do. One wire and one stent will go.
So 5 and a 6 will go.
Yes,
You
yes.
take an extra wire and stent.
Yes.
Okay.
So that is one. Or if you have a 6
very
guide
important.
extension, it's 7
Can
and
it
6
not be done with placement of ostium is very important. So is it not possible to keep the IVUS catheter along with this and position the stent?
Yes, it depends on two things. One, you need an 8 French guide catheter for this. And second thing is, it also depends on the lie of the circumflex and how you are going to image the ostium. Many a times, no, it's not. The lies are not, if they are very perpendicular, and sometimes you not tack it correctly. The real-time guidance, for ostial stenting. That's why it's not very popular. And also,
sometimes it's a miss because I've seen quite a few times perfectly position, no movement. When you just inflate the balloon, stent moves slightly.
Yeah.
There you have no control because you have no control when the balloon starts inflating, the stent slightly moves. Sometimes it's just hit or miss. So, Karthik Kannavaran, are you ready?
Yes, sir. Yes, sir.
Yeah, can you share your slides, please?
Yes.
This Ultra HD iris catheter is quite small, so it may, I don't know whether we can try a 7 French for the stent and Ultra HD catheter. Is it possible? I have not tried that yet. So Karthik, yes, we are
Yes, sir.
do the.
Can you
Yeah, we can
see
see
me?
yours. You can see yours, Karthik.
Yes, sir. Yes, sir.
Let's trying a JL 4 7 French and
7 French.
crossing. Yes.
Yes, a difficulty in
There we
crossing,
are.
and so we were just pecking, and after over a period of time, I think we took almost to a 10 to 12 on the same place. Successfully crossed the lesion, and the rotor bore entered to the distal L6. And after that, during the process of removing the rotor bar, unfortunately we lost the wire, but somehow we could able to cross the lesion with the workhorse wire. Then the lesion was pre-dilated with NC 2.5 into 10 balloon. And the stent was delivered into the LCX. We couldn't deliver the stent in the first attempt, so we had to use guide press to deliver the stent. So just after the L6 ostium to the distal L6. And this is the final shot of the L6. And we proceeded to left main to L6, left main to LAD stenting. This time we could able to encase the guide properly, and because of LAD and the guide was sitting coaxially in the LAD position, LAD direction. The lesion was crossed with the floppy wire, and the same 1.5 bar was used in the LAD lesion.
LED lesion.
LAD lesion, yeah. So unless L6 LAD was pretty smooth, and we could able to shave the calcium very well. And we pre-dilated the LAD lesion with 2.75 into 10 NC balloon. And this time also we couldn't deliver the stent in the initial attempt, so we had to use guide plus to deliver the stent, because the stent size was 3.8 and 38 millimeter in size. And we post-dilated the stent with 3 into 10 NC balloon in the mid and proximal and the distal mid LAD, and we used 4 into 8 balloon in the left mine. And this is the final trick shot. And this is the stent boost before pot of left mine, and this is after the pot. Finally, we used IVUS for the for the post deployment assessment of left main to LAD, and we found the narrowest portion at the ostium of the left main, but the LMA was 6.85, so we left alone because of the almost 270 to 360-degree calcium. So my learning points from this case and coaxially engaged guide is must for the smooth rotor ablation, and slow and constant picking motion during rota is very important, and we have to wait in between for the coronaries adequately for the coronaries to breathe. So these are the keys for the success of the rota ablation. And removing the bud and the rota wire exchange, it's a critical step in rota ablation. So failing which we may end up in trouble. Thanks.
Good case, Karthik. I think now we could see everything. Why did he choose to do circumflex first rota? Because problem is he always try to fix the circumflex, of course, is a vessel, but I think the LAD is the most important vessel in any case, isn't it? Yeah. So what, for example, if you have circumflex stent into the left main, you'll be in case if your right rota the LAD after that, there will be trouble, isn't it? Okay. In case you move the left circumflex stent into the LAD crossover, then unnecessarily you'll be it's going to be difficult. So my suggestion is do the rota of the main vessel first, don't do dilatation, then rota the side vessel, then prepare the side vessel, and then you do the usual things. So, but rota of the main vessel should be the first thing, then the side vessel.
Okay, sir.
That's my suggestion.
Okay, sir.
Yes, here everything went very well, and it's like T stenting, isn't it?
Yes, sir. Yes, sir. T stenting. T stenting.
This T stenting always failed me. I could never land it properly like yours, but it looks good. But the thing is, the T stent I could never get it right, so I don't do T stents.
What is your favorite, Saravana?
Crush
always.
Crush, always.
But this is a nearly 80-degree angle.
Nah, it doesn't matter. You can crush anything. Yeah.
So what was the angle?
Initially, I thought of putting a stent from the proximal L6 to the distal L6 because I could see a proper. I could not see any lesion in the ostium of the L6. So I planned L6 first and put a stent from the proximal L6 to. I didn't plan the stent from the L6 ostium.
Because of elongation, isn't it? Because
yes, sir. Yes, sir. It's the elongation.
But you covered it. This is a good elongation because you covered the little area where it's no drug there.
No. And I could see a small gap in the lower side, sir.
That's okay. Opposite to the because you're going to land 3 mm downstream anyway, isn't it?
Yes, sir.
So here it's better. You have only 1 mm missed. That's not bad when compared to this 3 mm, which is good. But always do the main vessel first. Don't compromise because in case if something happens, you'll be ending up quickly picking circumflex and then forgetting about LAD. LAD is always very, very important. So don't. The priority of the vessel should be LAD first, fixing it and then circumflex. But definitely circumflex stenting is okay, but prepare the LAD first before going for circumflex.
Yes, sir. Yes, sir. Very good point.
When you're doing the non-left main bifurcations, and you are a little worried about T, crush and all that, a DK mini culotte also works well. In fact, DK mini culotte ensures that you are always well covered and, after the first kiss, the things become very smooth. So you can have, now with all the stents which are having decent expansion limits, DK mini culotte also is, and even for left main bifurcation also, you can have a very short this one protrusion and then mini culotte. So it works. And also sometimes what happens is you are done an osteal LAD stenting and then osteal circumflex will be now deceased after a few years. And then what happens is you have to make a choice. It will become either a step crush or a culotte. So because all the osteal LAD stentings, some percent of the patients will come back to you with osteal circumflex, and then your strategy in your mind will be only either depends on how the wire crossed. If the wire crossed side of the stent, then it will become a crush. Otherwise, if it cross through the stent, it will become a culotte. So the DK mini culotte is a good addition. It's a very nice technique, actually, much better than I personally feel than the traditional culotte.
I don't do culotte, but if you are doing culotte, I think this Merrill's branch where
Yes, yeah.
actually it should be quite a good option if you're doing it. The branch.
No, the problem is the branch stent is the length on the side branch is limited,
Yes,
and the side branch osteal part is closed cell, so you can't expand quite much. And also the side branch length, I think, is 9 or 12 is maximum you can go. That's the problem. Yeah, that's the reason why the DK mini culotte, no, you can use a traditional stent and then come out nicely expanded, and then the short segment, no, once you kiss, it becomes very nice for the main branch stent to go, and then becomes like a traditional kissing. And see, it's either it's a choice between having a crushed mangled metal on the side versus a well opposed stent. It's just that you can't do a head to head, but then aesthetically and imaging wise, it looks good. Is Karthikeyan ready, or will Sridhar?
No, sir. He's still in the procedure. May take another 10 minutes. I just checked now.
Yeah, I think if he's not in a position, I think
no, Dr. Madhavan is here. Madhavan, sir.
Yeah, we can ask sir.
Tell me, Saravanan.
No, sir. Your suggestions for left main and things, sir.
Left mains, as
your
you said,
technique for
mini clot, I have worked, right? Stent, quite a lot I do it, and followed by crush technique, mini crush. Okay. So tap stent and mini clot, I have not tried. Culotte I have tried, and as Dr. Karthikeyan mentioned, in non-left main cases, few cases I have tried.
The concern about the culotte.
It's an excellent case, but
the concern about
yes.
The concern about culotte I always have is I lose that main branch wire. If here in crush, I always have the main branch wire. Whatever happens, my main branch is secured. I may lose side branch, but the main branch is always there. That's one thing nice about any type of crush technique. Yes. But culotte, I think, is a very beautiful one. But I think we have to master in one of it, whether you don't have to master both. One should be a default strategy. Yes. Another one, you can use one wire.
See, actually,
one of the areas where culotte is very useful is circumflex and good size marginal. Okay. In that area, culotte is really very useful.
Actually, when we are taught, we were always taught tap. Tap and culotte will come together because tap is the one bailout technique. So tap is always a good bailout technique. And then once we learn DK crush, then any crush is okay. And then the step crush, sometimes, instead of crushing, instead of doing DK, initially we were taught step crush also. Step crush is when this scenario where I told, osteal stent is there, and then circumflex ostium is got stenosed. And then you're doing it after a few years. Then just a balloon dilatation into the left main circumflex, and then get the studs out of the way, and then left main to circumflex kissing and coming out. So step crush actually is what the second iteration after the traditional crush. So step crush also is, so basically we just, if you know DK crush and a tap, then we can do most of the things because we have already have one bailout technique and one elective two stent technique, and that encompasses the techniques. Culotte is just an extension of the tap only. Instead of a partial protrusion, you can always have a full protrusion and plan it from the beginning, and then secure your side branch if it's really very large one and difficult one. In fact, now after CT studies, we know that more than 2 is one thing, and length should be more than 73 millimeters for a functionally significant side branch. So if it's less than 73 millimeters, then all the effort you do maybe not something. That's something we have to think about, because is the vessel long enough also is important. And any technique which suits us, because ultimately the operator must be comfortable with what he is doing. So whatever is, I think the bailout, always tap is a good bailout technique. And that is something, and with a good stent boost and thing, we can have very good ostial coverage. It's very rarely that tap is missed. And the only thing is when we are doing the pot, we should be careful not to distort the stent. Otherwise, we are good. Tap is a good bailout technique, and then any crush technique which we are comfortable, I think, is good enough. And when we're doing crossovers, always know your stent well and image, because I don't know if you are in a center where there's no imaging and you are forced to do a left main stenting. One tip we were taught when I was in Toulouse was that whatever you think is your left main size, 0.5 mm more should be the total of pot size. So if you think your left main is 4, then at least 4.5 mm balloon dilatation should be done for pot, because you don't want to have malposition and all that. So always the sizing of left main angiographically, we tend to undersize. So that is something, of course, by default now we do always left main with imaging, but if you're in a center with no imaging, or that day your imaging equipment fails to function or something, and then you must have some angiogram markers or angio ways of doing the good old way of doing left main stenting without imaging.
If there's no any further questions from the audience, anybody?
Yeah, is there the box? Anybody has typed questions? Have we chat box?
No.
I don't see any questions from the chat box. Vijay is here.
Vijay came in between and went left, I think.
Okay.
Vijay is here, yes.
I'm there, Karthik. The internet is not very good.
Okay. No, we're just talking about.
Show your face, please.
Yeah. Well, you have done a little bit of DK mini culotte, no? Recent few cases. Oh, how has been the imaging, and what is your take on DK mini culotte?
No, the biggest advantage is you don't have any struts, and no neocurrent if you enter correctly.
Yes.
So it's the biggest advantage. That's better if you achieve distal cross both the times, and you have a very good result.
So, because I know you have done with imaging in left main also. That's why I thought I'll take your. Because I have used it only for non-left main.
Yeah, recently also we did I think last week before one case we did. But see, the thing is you enter distal both the times and you get very good results.
Yeah. But once we do a good pot on the the stent which is protruding, the short segment of protrusion, then a distal cross even angiographically is most of the time possible.
In left main it is not a big problem at all, because it is so most of the time you get, and provided is now with all the stents, with the 2 connector stents and the things, you don't get much deformation also. And Megatron, and you see that crossing your Megatron plus if you use a stent boost.
Yeah.
It is most of the time you get a very good thing. I think EBC still says, right, it is no IVAS, nothing. It is no, everything is on fluoroscopic radar. But they use a stent boost, stent enhancement extensively during. So particularly good mirror means stents with radio opacity like Megatron. Yes. And it is very, very easy to recognize and correct even some longitudinal deformation happens.
True.
It is.
And in fact, the other day when we were doing a case, you showed that how our we do, and we don't get our pot balloon very coaxial. When we do the flaring, you can end up with stent deformation. That's important thing. We always think that the final, when we are doing ostial flaring, the balloon position does not matter, but the balloon has to be really coaxial. Otherwise, we can end up distorting the stent as well.
No, I think it is when you do left main, it's very, very important to use good stents with a good radio opacity. So then, and any form of deformation you can easily recognize, because all the labs offer good quality stent enhancement. Whether you have GE, Philips, Siemens, and it is and most of the time you can do an optimal stenting, provided that your lesion preparation is good.
Yes.
You can hear me, Karthik? Okay.
Yes, I
We
can
can
hear
hear
you.
you.
Yeah. Just still I'm in the car so
Oh,
from
okay.
Trichy to Tiruppur.
Sure. Anything for ACERT in Boston. So
And for left main stenting, Megatron is a game changer.
True,
I
true.
think almost using, right?
How come, Madhan sir, how come Sridhar couldn't convince you for Megatron?
No, I have not used Saravana.
How come,
I have not
sir?
used it.
Because
I have not
how
used
come
it.
Sridhar, what's happening?
No,
So I have not used. So that's why I'm
It's a
keeping
good stand,
quiet.
sir.
it's a very
It's a
good
good
stand.
stand because two reason is it's thicker. It got more radial strength and the expandability from 3.5 it goes to 5.56 easily without
I see.
major distortion. That's one thing I can notice. But it's very bulky, stiff stand because I don't like to use it in a tortuous or like a RCA where
Like Cypher.
yes, it is.
Is
And
it like Cypher?
yes, it's I don't know the set thickness that they have. It's smaller than Cypher, but it's
Cypher is 110, I believe.
The
Yeah,
Cypher
110.
was more, sir.
Cypher,
And it is made for
Cypher is 110,
minor
no?
big vessels anyway. It's made
but
for
our
that.
biofreedom is now 110. Our regular currently
it
available.
doesn't take the curve. The delivery is somewhat difficult in distal vessel and things. So definitely only for left main alone. I don't think it can be for any tortuous vessel. It should not be used. That's what I think.
I've used it in RCA also, osteoproximal RCA. I've used it. It's quite good. The vessel size has to be big and nice.
No,
For
no, I'm just saying, like, if you're trying to take it for a non-branch, I don't think that's any additional value.
Yeah, true.
And I mean, maybe for every calcified vessel, it may give extra strength.
Yeah.
But it's only for, I think left main, it works.
Left main, it's designed for left main and large vessels.
Is it more radio effects?
Yes.
It is, yes, sir.
Yes.
It's good, like, but the size are not very long. Like,
Yeah.
the thing is, a 3.5 is very good to go up to 6. That's the confidence you can have without much distortion of the stent. But everything else look distorted after
And you
stretching.
can see the differences right away, as Saravana is telling. No, this. And previously, old generation stents you use, and you see a lot of gap between studs, right? That
Yes,
you don't
true.
see with
Don't see
Megatron.
that. That's the one. That's a big thing you can notice it.
Yeah. In fact, we have a short segment, no? Left main into LAD, it's less than 30, or I think 28 is the longest we have. Sridhar, what is the longest you have in
32.
32, yeah.
32.
So that is the limiting factor, 32, that's the length. And otherwise, if we are good. And 3.5 itself goes to a very good dimension. I think 4, you can take it easily to 6.
Yeah. No, 3.5, everything is same stent.
Yeah, say the balloon only is different.
Yes, the
3.5
balloon is different. Everything is same stent. I think we can conclude. What do you think, Dr.
Yeah, I think so. I'll now that Karthikeyan is not available, I think I'll take this opportunity to thank our experts for spend their valuable time, and also the presenters for all their very interesting cases, because that stimulates good discussion and also some tips and tricks as we go along. So thank you very much for all the case presenters, and thanks to Prabhakar sir for facilitating the program. And I take this opportunity to wish you all good night until we meet again. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you. So.